Good evening, everyone, and thanks so much for joining us tonight for an update on Parkinson's disease diagnosis and management. Presenting for us tonight is Professor Simon Hawke, whose bio you hopefully have had a chance to read by now. Just like to start tonight's meeting by acknowledging the people of the Wiradjuri Nation and the different nations on which people here sit tonight. I'd like to acknowledge that we work on the traditional lands of many Aboriginal clans and nations and pay respect to elders past, present and emerging, and acknowledge their continuing connection to land, water and culture, and for their contribution to help shape the life of the communities in which we all work and live. We are committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social wellbeing. I welcome Aboriginal and Torres Strait Islander Australians who are present in this meeting tonight. If you're not familiar with GoToWebinar, the controls are pretty easy. If you can't see the big control panel, just click on the small orange arrow, which is at the top right-hand side of your screen. And your panel should open up like that. Everyone's automatically on mute to optimise the sound quality. So if you have a question, please use the questions box and our presenter will respond as we progress through the webinar. Just click on the small triangle to open up the questions box and type your questions. I'm just trying to fix up the presentation here. Excuse me for a moment. Okay. So I'd like to hand over to Dr. Hawke tonight if I can.
Thanks very much, Liz, and welcome to everyone. I'm sorry that I can't see you and you can't see me. I mean, probably better if you can't see me, but I understand there's more than 60 people in on the meeting, which is fantastic. I'm a neurologist in Orange. I was working quite a lot in Sydney, but I'm mainly in Orange now. What I'd like to do is give you an overview of Parkinson's and talk about some recent advances, but hopefully at the end of the day, you'll get a feel for what Parkinson's disease is, how we come to making a diagnosis, how we, what sort of issues there are with treatment, and there'll be an opportunity for you to ask questions either throughout or at the end, and Liz will control the questions and also the slides. Okay, could I have the first slide, please, Liz? Second slide, I would have to say. Okay. Now, we all know Parkinson's disease is a very common disease. It's estimated that 100,000 Australians have Parkinson's disease. There are about 13,000 new cases each year. It's the second most common neurodegenerative disease after Alzheimer's disease. I guess as a neurologist, I would see one new patient every couple of weeks, I guess, sometimes more than one a week. And I would definitely see a number of people with Parkinson's, in follow-up, maybe 6 or more every week. It's a disease of the older age group, but we do have younger patients with Parkinson's and even a few patients in their 40s. It's slowly progressive, as we know, and unfortunately, there's no cure. And this comes from the Sydney Parkinson's study, which was one of the first long-term follow-up studies, which was driven by Maurice Healy, who's a neurologist in Bowral, who's recently retired, and this was published in Movement Disorders in 2008, that about 26% were alive 20 years from diagnosis. And that certainly gives you a lot of time to end up with a lot of the problems of advanced Parkinson's disease. Can I have the next slide, please? We all know about the aging demographics. So for all neurodegenerative diseases, we've got problems unless we can come to developing agents which affect brain cell degeneration, because the population is aging, and obviously putting more and more issues and stresses on resources. Probably about 25% more patients by 2050. The next slide, please. At the heart of Parkinson's and other neurodegenerative disease is the misfolding of protein. That seems to be a hallmark that's common to each of the diseases. The only issue is that each neurodegenerative disease has a different protein, but the end result is that a native protein folds abnormally and associates into fibrils, which are like rods of proteins that elongate, and these little filaments accumulate in neurons, which of course live for many years usually, but eventually they cause toxicity and the neurons die off. Now each of the diseases has emphases in which neurons are affected, and in part that's or maybe wholly related to the protein that's accumulating. And there are many other much rarer neurodegenerative diseases that are associated with different protein accumulations. Could I have the next slide, please? So this is from a recent review on Parkinson's, and the misfolding and the aggregation, that's the forming of the filaments you can see over on the left. But then these proteins normally have to be dealt with by proteolytic machinery in the cells, and some people are working pretty hard to try and work out if the primary problem in neurodegenerative disease is that the mechanisms that are required to, if you like, metabolize junk protein become overwhelmed for some reason. Now, whether that's the main issue, there's certainly mitochondrial dysfunction in neurons, and certainly in some neurodegenerative disease, there's neuroinflammation. But this is not so much inflammation from adaptive immunity, from T and B lymphocytes. It's more that the innate immune cells, the microglial cells, are some of which differentiate from monocytes from the periphery, but some are resident in the brain. They are overactive, and they may contribute to the neuronal death. Now, one thing that seems to be common in a lot of these diseases is that the disease starts in one area and then spreads. And we all know that CJD, or mad cow disease in bovine spongiform encephalopathy, is an infectious disorder. People have determined that even the aggregated fibrils from neurons from patients from Parkinson's disease and from tau and A-beta proteins in Alzheimer's can be transmissible, but not in the same way, thankfully, as what happens with CJD. But there are definite parallels between these disorders. Could I have the next slide, please?
We just have a question from Alexander. Dr. Hawke, he's asking, is the pathogenesis different in young onset Parkinson's?
No, but young onset is much more likely to be genetic, which may promote the misfolding. But the pathogenesis and the clinical course of the usual familial Parkinson's is rather similar. Could I have the next slide, please? So the hallmark of Parkinson's, as you know, is a loss of these dopaminergic neurons in the substantia nigra, and that's that black line. that you see with the red arrow, and you eventually end up with no dopaminergic neurons, and they've been stained in the panels below. And you'd have thought, you can see that quite clearly on an MRI, and you thought, well, why can't we use that as a diagnostic tool for Parkinson's? And you certainly can sometimes see that one side is affected more, and sometimes it's appropriate if the Parkinson's is affecting the contralateral, the other side of the body, to a greater degree. But unfortunately, it's not sufficiently sensitive or specific. Could I have the next slide, please? And what happens is that the accumulation of the alpha-synuclein protein in neurons, you end up with these dying neurons with this massive alpha-synuclein in the neuron, and they're called Lewy bodies, which is not specific to Parkinson's disease, but it's the common pathological feature when the neurons are dying off. Could I have the next slide, please? Now, perhaps more useful might be a fluorodopa PET scan, but unfortunately, because we only have a couple of reactors, or one reactor really that produces isotopes at Lucas Heights in Sydney, and I don't know the technical details, but the actual isotopes that can be conjugated to fluorine and then conjugated to dopamine, which would accumulate in the nerve cells in the brain. We can't do this PET scan, but many countries can do this, and it's quite useful to confirm, although it doesn't differentiate between Parkinson's and other types of Parkinson-like neurodegenerative disease. Could I have the next slide, please? And I've just touched on the genetics. Genetic patients tend to be younger, and there's a whole heap of genes now that have been identified, over 20 monogenic forms, and they can be autosomal dominant or recessive, and they seem to be involved in these functions: mitochondrial dysfunction, stress, oxidative stress in the mitochondria, protein aggregation, and this UPS, which is the mechanism where the proteins get degraded. So there's logic behind what we think might be going on in the disease, but unfortunately it's very hard to work on the basic science of these neurodegenerative diseases because you have to have good animal models. They tend not to be that good and somewhat artificial. And unless you've got a good animal model, it's very difficult to get to the detail of the underlying mechanisms of disease. So that's my view as to why we haven't been able to reach this final frontier for neurodegenerative disease and turn off neurons from dying. Could I have the next slide, please? Okay, so Parkinson's disease, we all know about this, and if you could see me, I'm holding up the actual book by James Parkinson, an essay on the shaking palsy, which was published in London in 1817 by the Royal College of Surgeons, interestingly. Anyway, classical features: resting tremor, slowness of movement, rigidity of muscles, a stooped posture. So they're the main motor features of Parkinson's. Tremor itself, of course, can occur early on, just on its own. And the disability in terms of the motor dysfunction really doesn't come so much from the tremor, more so from the slowness of movement and the bradykinesia and the muscular rigidity. And before we had any treatment, people would just end up basically completely rigid and unable to move, shaking in nursing homes. Could I have the next slide, please? But we now know, of course, that with Parkinson's disease, there are subtle features of it that can predate the motor dysfunction by many, many years. So if you look at the panel on the left, which says prodromal, people think that you could quite easily be starting off developing abnormalities, 15, 20 years before any motor dysfunction. And loss of smell is one feature that often predates the onset of the disease by many years. REM sleep behavior disorder, we'll go into that in a bit more detail. Then you end up with the classical sort of features of the motor features. You get worsening fluctuations, so we'll go into all of that, and then you have worsening non-motor features. So that's a sort of basic overview with a time course. And from a Sydney Parkinson's disease study, as I said, 26% of people are still alive 20 years after the diagnosis, but 80% of those actually have dementia. So usually dementia will end up getting you in the end with Parkinson's, unfortunately. Could I have the next slide, please? So this is the way I look at a patient with Parkinson's. Typical clinical syndrome and signs. So they're the motor features. And then we're looking into excluding, so the first lot of symptoms I would sort of put under the rubric of that patient has Parkinsonism, tremor, sometimes rigidity, slowness of movement, stooped posture, shuffling gait, poor postural instability. They're the sort of motor features. And then we look, when we examine the patient, for an absence of significant eye movement abnormalities, so failure of vertical gaze. You sometimes see in Parkinson's, but if you see that early on and the patient has a lot of falls, then you think of progressive supranuclear palsy. Early postural hypotension or autonomic dysfunction, think of the Shire-Drager syndrome or multisystem atrophy, Parkinson variant. That's pretty rare. Completely unilateral but severe motor dysfunction in one hand, for instance, without much tremor. You can think of things like corticobasal degeneration. Again, that's quite rare, but we do have a number of patients with it. And then other features, you shouldn't really have pyramidal signs, even though the patient will often tell you that they have weakness with Parkinson's. When you actually test them, they never have weakness. If you see weakness, it's not going to be Parkinson's. Early hallucinations and cognitive impairment, that if they've been prominent, a year before you get any motor features, you should be thinking of things like dementia with Lewy bodies. So they're the sort of things that go through your mind. And I always do an MRI because that should be normal. I mentioned that what you might see is loss of the substantia nigra signal, particularly on the susceptibility weighted imaging, but it's not that useful, as I mentioned. And you want to see that there's no lesion in the midbrain. You want to see there's no hydrocephalus. You want to make sure there's no tumor. You want to make sure there's not a lot of multiple strokes, because those things can suggest other forms of Parkinson's. Just make sure the patient's not on any antipsychotics or antiemetics. That's going to be pretty obvious. But the main feature, given the above, to me, that gives you the diagnosis is that they respond to dopaminergic treatment. And if they don't respond to dopaminergic treatment, then you have to have doubt about whether it's Parkinson's. Now, just to put that into perspective, in the UK, where I was a neurologist before I came back to Australia, there are not that many neurologists, and there are more now than there were, but neurologists in the UK would just spend pretty much all their time seeing neurodegenerative disease, very experienced, but even experienced neurologists get the diagnosis wrong about 10% of the time, and that's based on the UK Parkinson's disease brain bank. So that's like the final arbiter of the diagnosis. So I don't think we need to be too concerned about saying to the patient, look, we're not going to be absolutely 100% effective, and sometimes, you know, we are wrong. It does help the neurologist if the patient's got all the signs, and it's very tempting, I know, when you see somebody who's clearly got Parkinson's, to whack them on dopaminergic therapy, and then the symptoms all go, because what we like to see if the patient's got Parkinson's disease is they go back to normal in the early stages. And when you see the person in your office for the first time and you realize that you could be seeing this person for the next 15, 20 years, it's nice to be certain yourself that they've got the response to treatment. So I don't encourage people to put the patient on dopaminergic therapy. One way around that might be doing a video before and after treatment. There'll be other ways around it. Next slide, please, Liz. Okay, this is just a typical patient. If we could just roll that video. And this guy is doesn't have particularly hypomimic face, so an expressionless face. His voice is pretty normal. And this is a rather subtle tremor that he's got, and it's really only brought out when he gets a bit anxious. And you can get the patient to count back from 100 by 7s or 2s, depending on how you think they're going to go, anything to raise their stress levels, and that's what he's doing. And you'll see that the subtle tremor emerges. There's something wrong with the video, Liz. That's slow. I don't know, because that tremor is too slow for Parkinson's. See that left arm shaking? Well, that should be faster. It should be 5 hertz.
We might try the other videos for the next
Okay.
lot then.
Okay. Let's go to the next one. And you can actually, I mean, for a while I got very excited by using using my accelerometer on my iPhone to actually measure the frequency of the tremor. But it's pretty obvious, you know, if it's a slow tremor rather than the fine tremor of the central tremor. Anyway, it was quite a nice. It's very consistent, the resting tremor of Parkinson's. You really need to get the patient to relax and be completely still, and then it sometimes will emerge, particularly if the patient gets stressed. All tremor gets worse when patients get stressed. And as soon as they lift their arm or as soon as they touch their fingers together, it disappears. So hence the tremor itself is not a disabling feature usually. Some people, of course, don't have more than one type of tremor with Parkinson's. So the next slide, please. Okay, let's another patient, guy in his 50s. Let's roll that one.
Name's Peter Scholes. The date's the 21st of June 2017. Don't mind you doing a video on treatment and outcomes.
Okay, we'll just get you to walk up and down as you did.
We'll just get you to walk up and down as you did.
And then do the turn. That's good. And then turn around again.
That's good. And then turn around again.
Now, you were saying that what were you doing in April?
Masters hockey in April.
And you're still playing hockey?
No, I only go to the state.
And you're still playing hockey?
Veterans, but 50 years I've been playing.
Are you still training though and running? And
Yes,
Are you still training though and running?
2 times a week. Do spin classes, cross trainer, rowing.
Yep. How about like this? Can you walk like this, heel touching your toe?
How about like this? Can you walk like this, heel touching your toe?
Okay, now put your feet together.
Okay, now
and then
put
when
your
you're
feet
steady,
together.
close your eyes.
And then when you're steady, close your eyes.
That's good. Now put your hand out in front of you like this.
Good. Now put your hand out in front of you like this.
And then touch your nose like this slowly.
And then touch your nose like this slowly.
And same with the other one.
Same with the other one.
And then put your both of your hands out again.
And put your both of your
Not
hands
much
out
tremor
again.
like that.
Not much tremor
And then
like
can you
that.
just tap on the back of your hand like this with one
and then can
finger?
you just tap on the back of your hand
Fast
like
as,
this?
no, sorry, with 2 fingers. My fault.
Fast
as you
sorry,
can.
2 fingers. My fault.
And then
Fast as you
same with the
can.
other one.
And then same with the other
Better
one.
on that side. Are you right or left-handed?
Right-handed.
It's better on that
Okay.
side. You
Now
right
I
or
want you to look at
left-handed?
my 2 fingers here.
Okay. Now I want you to look at my
up.
2 fingers here. Look up.
Good.
Okay, let's go back. I don't know if you can hear me. Right.
We can
you hear me now? Yeah. Okay, so anyway, that's that guy's brain. And you can see on the left panel, the substantia nigra. It looks like a little mouse with a nose and 2 eyes and the ears. You see that? Those dark bits in the ears are where the pars compacta of substantia nigra is, the dopaminergic neuron. But you don't see anything. He's got a couple of little white spots, but you're allowed 1 for each decade of life. So you could see that the rapid movement in that gentleman's hands, particularly on the right, which should be much better, your dominant hand, than the other side, rapid finger tapping was severely impaired, and bradykinesia, on-block turning, and yet he was still able to run and play hockey. Could I have the next slide, please? Okay, so sort of touched a bit about the differential diagnosis. Now, essential tremor, of course, is a fine tremor that many people have. It's often autosomal dominant. It interferes with writing. It's very, very common. It responds often to beta blockers. One trick about the essential tremor is that as you get older, it becomes much slower and much more coarse. So if you see someone with a flapping tremor that seems quite slow, it may well not be Parkinson's. And flapping tremors in people in their 70s and 80s, as I'm sure you know, is very disabling, and treatment is not that effective. Drug-induced Parkinsonism occurs with pretty much any of the antipsychotic medication, perhaps except clozapine. Age-related Parkinson. Now, that's an interesting one because people have done studies of unselected people in their 80s and 90s, and you can often find some Parkinson's sign in somebody in their late 80s, but it's very unlikely that they've got Parkinson's. So unless they've got like a full hand of signs, I think it's usually, in my experience, treatment doesn't usually work. So it's just age-related Parkinson's. Vascular Parkinsonism, lots of little mini strokes, of course, is well recognized, like vascular dementia. It's always worth treating people to see whether it does something. And I've gone through atypical Parkinson's syndromes. I would say, dementia with Lewy bodies is probably the commonest. PSP, we have a number of people with it. CBD, likewise. MSA is very uncommon. There's 2 types, a cerebellar variant and a Parkinson's variant. And there are some MRI features. Try the next slide. Okay, just start this one and see how we go with this.
My name's Jane Harris, and
I give permission for Dr. Hawke to use
I don't know if you can still hear me.
the tremors that I have for educational purposes.
Okay,
Yes, we can, Dr. Hawke.
just put your hands out in
Okay, that's
front of you.
good. So this is, you basically, you know, get the patient to stick their hands out, and you can see there's
And
a
then
very
just turn your hand on
fine
this side like
tremor.
this and just rub
Sometimes
your
if you
fingers.
amplify it, you can amplify it by putting them on the side and extending the fingers. See how it's just coming out there? And you can really tell if someone's got Parkinson's. Often, you know, the bradykinesia, the flat face, hypomimia, the soft voice. So this lady clearly doesn't have any Parkinson's, and her movements and everything are quite fast.
And then I want you to do this tapping on the back of your hand, that one that I did. Fast as you can.
You just tell when you talk to somebody, there's spontaneous movements. You know, they're slow.
And then just let me see you walk up and down here.
Particularly on one side, if she gets up quickly and
Back
swings
over the
around.
door, over the door, ma'am.
So the next slide, please. Okay, let's run this video.
Sorry, Dr. Hawke, this is a different one. Just
Yes.
give me a moment.
Okay.
It's the older gentleman with glasses. Do you want to run with that one at this stage?
Just pass over that one.
Okay.
We haven't got that last one because I saw the picture. I saw the patient. It was a lady.
Just check.
I think I deleted the other one.
Yes. Here it is.
There we go.
And the date today is the 30th of October.
And do you mind me taking this video for purposes of comparing you pre and post treatment? Let me see you walk up and down here.
So this is a lady in her 50s.
And then over to the door.
Early 60s, I think, who had a lot of falls. And so early falls don't usually occur in Parkinson's disease. Usually the people have had the disease for a while, but you can see she's not swinging her arms, and she's got a very fine tremor of particularly the left hand. And these patients often have what I sort of would term starey eyes, and they have very poor postural reflexes. And if we go to the next slide, when we're back on the main deck. So here, this is a patient with PSP. So early falls, failure of voluntary vertical gaze, and preserved involuntary movements, and eye movements, and you do that by getting the patient to fixate on a single point in front of them, and you move their head up and down, and their eyes move up and down normally while they're watching this single point. But if they try and move their eyes up or down, they can't. And this MRI shows quite a lot of atrophy, but there's particular atrophy of the midbrain, and it looks almost like a bird with a beak. Do you see that in the midbrain? Now sometimes you see that with multiple mini strokes, but that's pretty typical of PSP. I must say I don't usually do more than one MRI, but if sometimes I think the patient might be morphing into something else, or I'm not completely convinced, I might repeat it to see whether something's emerged. But yeah, if you saw that and that patient, you'd think, that's probably not Parkinson's. We might try some treatment. Okay, could I have the next slide, please? So it may not work. Okay, there are different subtypes, and we talked a little bit about the younger onset patient, and there are subtypes of young onset depending on which gene that the patient has, but overall, the common younger onset patient usually has a good response to treatment. They behave just like normal Parkinson's in the early stages. They can be, the best type of Parkinson's is to have tremor dominant Parkinson's, and if it starts on one side without much rigidity, that usually has a better prognosis. The worst type of Parkinson's to have is the patients who just have rigidity without much tremor. They often have very early cognitive decline, and there are another subtype where the patients really decline extremely quickly. It's almost like it's a different disease. This is from a paper by Simon Lewis, who's a neurologist colleague from the University of Sydney, who used to come to Dubbo. Some of you will know him. Could I have the next slide, please? Okay, so we're talking about treatment in the early stages to try and improve the amount of dopamine that's released from the neurons in the substantia nigra, and this is a schematic of the dopaminergic cell. And just on the left, upper left, we just have to remember that Parkinson's is not just a disease of the dopaminergic system, and other systems are involved. And maybe we'll have drugs to target those other systems in due course. The mainstay of treatment, the initial treatment, was levodopa, which is taken up by the dopaminergic cell and converted to dopamine where it's released. And then there are various mechanisms to improve the amount of dopamine. Now, firstly, we, as you know, that the common drugs Sinemet and Matapar or Kinson are a combination drug. So very early on, it was worked out in the 50s that you had to give huge amounts of levodopa to get any response in the brain. Almost grams of the stuff. And that's because there's a lot of dopamine outside the brain. There's lots of mechanisms to break it down. And it's a tough ask to go from a tablet through the gut, be absorbed, and get into the brain. So we have these other drugs to break down, to stop the enzymes, to inhibit the enzymes that break down the dopamine, dopa decarboxylase being one, and then the COMT enzyme, some of which is in the periphery, and with one or two of the drugs, it also works on the central COMT, another enzyme which blocks it down in the synapse. Dopamine agonists are rather weaker agents, but convenient because they can be given once a day, and they work on the dopaminergic receptor, but they're not nearly as potent as levodopa. The MAOB inhibitors out on the right-hand side, they block an enzyme which pumps the dopamine out of the cell, but not of the synapse, so it basically increases the amount of dopamine in the neuron. So they work either to improve your own production in your remaining nerve cells, or to improve the levels of the dopamine that the nerve cells have taken up. And then we have anticholinergic inhibitors which block the downstream circuits. Could I have the next slide, please? So this is a dilemma, and for a long time, apart from convenience, because it is very convenient to start with a drug once a day. So for a long time, my standard way I would treat someone with Parkinson's was to start off with a once-a-day agent, and before the Azilect or Rasagiline came into use, I would use a dopamine agonist and once daily dosage, and then build that up slowly, tell the patients all about the terrible side effects, which can be significant, and then come in with levodopa. Well, more recent studies and quite recent large studies have really shown that it doesn't really make any difference in the long term whether you start with a dopamine agonist or levodopa. And the key thing was that neurologists had this idea that if you sensitize the synapse to levodopa early, you made it much more likely to get supersensitivity of the downstream receptors, and you would end up with very early and much more marked dyskinesia. Certainly, dyskinesia is more a feature of something that's associated with dopamine, but in part it's the disease with, levodopa. And the evidence is that if you look down the track, 7 years, there's really not that much difference. And there may even be some evidence to suggest that you're better off having started with levodopa. So quite a lot of people now start with levodopa. And the problem, of course, of that is that you've got to take it 3 times a day. So that's difficult for younger people. Sometimes we use anticholinergics, not very often. Typically, they were used for people who only have tremor without much rigidity. Could I have the next slide, please? So I think it doesn't really matter. I think you start with levodopa or you start with a dopamine agonist. But when rasagiline became available, there's a paper in the New England Journal that suggested it might be neuroprotective. So that was extremely exciting. There was a paper in the New England Journal. I think subsequent studies have really not confirmed that, but its precursor, selegiline, which has been around for 20 years, neurologists always thought that people who were on it maybe did a little better. So, I had for a long time started people off rasagiline, then moved to a dopamine agonist, then moved because of the convenience, then moved to levodopa. But certainly now I'm doing a lot more starting off with levodopa, and I usually start with Matabar rather than Cinemed or Kinson. It is convenient though. It causes irreversible blocking of the enzyme. I think that its effect is probably not so neuroprotective. The modern analogs don't seem to have the same issues with methamphetamines interactions, but there are certain antidepressants that we avoid with Azilect. Go to the next slide. Dopamine agonists. Initially, we used a lot of cabergoline, but that causes fibrosis of the lung and heart valves. So we tend to use we don't use that hardly at all now. We use pramipexole or rotigotine patch. The rotigotine patch is convenient, and if you like this idea of having even stimulation of dopaminergic neurons, it's great because it just leaches out continuously. It lasts a long time. You don't have to be too fussed if the patient doesn't change it every 24 hours. You do get reactions to the patch, allergic reactions. You have to stop it. One of the problems is that it's not milligram for milligram with pramipexole or Cifrol. It's 4 times less potent. So if you switch somebody to the patch from oral Cifrol and you put them on the same milligrams, they often have terrible dopaminergic drug withdrawal. So I've talked a little bit about dopamine agonist versus levodopa. The main issue for my mind, and the great concern, is impulse control disorder. If people have a tendency to gamble, it can be made much worse. It seems to be particularly a problem with the dopamine agonists, but I have had one patient on high dose levodopa who also gambled, so it's not entirely related, but that's rare, and it's not rare. It's about 40% of people get some sort of impulse control problem. It may not be gambling, it might be shopping, it might be doing family history for 24 hours a day, it might be building and stripping down cars. There are all sorts of things. If you like doing something, you do more of it. It might be hypersexuality. There's a lot of different things. So some of my colleagues say, I'm never going to use a dopamine agonist. I think that's probably a little bit too strong. I think as long as everyone's aware, I do like to have the patient's family in on the consultation when we're talking about it. But certainly it can be useful. It can be useful initially, it can be useful later on to smooth out fluctuations. Could I have the next, please? Okay, so as the Parkinson's progresses, you're going to have to keep what I call about rebalancing the system. So initially you see the patient, they have a dopaminergic lack, you're rebalancing that with the medication, either quickly with levodopa or more slowly by escalating, finding a level of replacement where they're normal, and then you wait and you see what happens, because over time that will wear off, they'll start to get the symptoms back, and that's related to the dopaminergic neurons dying off. And it's a slow and steady fallout of the neurons, and you end up with motor fluctuations, wearing off, dyskinesias, you end up with postural instability, you end up with worsening non-motor symptoms. And it ends up as a terrible disease, as we all know. Could I have the next slide, please? It's just an algorithm. I think you can usually manage motor fluctuations reasonably well. Usually you get, some years of quite easy control in most patients. Then you need to reduce the interval between the doses of levodopa, add in other drugs to smooth out the fluctuations I mentioned. You can use amantadine to reduce the dyskinesias. But at the end of the day, some patients it seems to not last long at all. And I think you can think about that as being a parallel with the number of neurons that are in the right spot in the substantia nigra that can take up the dopamine. Once they've all gone, you're relying totally on the pharmacokinetics, the crossing of the blood-brain barrier, achieving reasonable amounts in the brain, and that's a very difficult issue. And so then we move on to other treatments when that happens. Could I have the next slide, please? Of the non-motor symptoms, impotence, constipation, urinary symptoms, gastroparesis, postural hypotension, these are all worrying and troublesome symptoms. We can do some things for some of them. The psychiatric manifestations in some patients are terrible and very difficult to treat. Dementia, of course, is quite common. Hallucinations, often refractory and difficult to treat. Anosmia, you just put up with it, nothing to do about that. Sleep disturbance, which can antedate, as I said at the start, the motor symptoms by a long time, can be treated, can be suppressed, and that can stop the partners being struck and hit and punched, as often occurs when the patient is asleep, acting out their dreams. Could I have the next slide, please? So if we take the non-motor manifestations, we usually go through a series of issues, a series of responses to them, say orthostatic hypotension, which can end up being totally disabling and the patients can't get out of a wheelchair or even stand up without fainting. But usually we start off by increasing salt and water intake. Domperidone is sometimes useful. And then fludrocortisone is used, the usual initial treatment. Just be aware that it's a steroid that can cause leaching of calcium. Usually you'd use caltrate and vitamin D with it. And then we usually move on to midodrine, which is a centrally acting agent, which works pretty well, but you need to get approval from Canberra for that. Anticholinergics for bladder overactivity, constipation, Movicol, and various other things, of course. Then if we talk about sialorrhea, you can use anticholinergics. So sometimes I would put people on Artane, watching out for making confusion worse. but that often works quite well. You can get them to gargle hyoscine drops, botulinum toxin into the parotids, and submandibular glands can be used. Psychosis is often a problem. We usually tend to use quetiapine, occasionally olanzapine, but that causes worsening of the Parkinson's often. Haloperidol will definitely make it much worse. Risperidone likewise. And there are some new drugs which have not hit Australia. One of which is called pimavanserin, which is a 5-HT2A antagonist that apparently is working quite well. That may end up coming to Australia. We definitely need other agents for the psychosis. Not necessarily so much for the hallucinations, because often patients are not so fussed if they're simple formed hallucinations. But once the patient gets worried and psychotic, it's very difficult. Got to minimize the dose of the Parkinson's agents, the dopaminergic drugs. That can help. Often, if the patient's got significant cognitive impairment, which is not on the list, we tend to use pyridostigmine, or we use memantine. So drugs for Alzheimer's, we're not really supposed to use them, but they can help. Sometimes they help psychosis. So the cholinergic esterase inhibitors. Could I have the next slide, please?
Have a question from Jenny. She's saying, in contrast to sialorrhea, can you get a very dry mouth in Parkinson's?
You can, because a lot of the drugs do have anticholinergic effects. Drooling, though, is that the patients often, well, they seem to complain more of that, but yes, dry mouth definitely occurs. Okay, this is a new drug.
Sorry, Dr. Hook, Jenny's just asked, in a person who's not on any medications with the sialorrhea, can you get a very dry mouth if you're not on any other medications?
If you're not on any other medication and you've got Parkinson's disease, I don't think that's very common, thinking about it. But, you know, autonomic dysfunction occurs in Parkinson's, so maybe that can occur. I'm more struck by the patient who's complaining of drooling rather than dry mouth, if I think about it.
We've got another question from Joshua. Are there any suggestions for medication disturbance in Parkinson's or PSP?
Sorry, are there any what, sorry?
Are there any suggestions for medications for sleep-wake cycle disturbance in Parkinson's or PSP?
I think we're not very good at treating that, melatonin, I don't think there's anything specific that's particularly useful. Okay, so the next, I just thought I'd just mention briefly this new drug called Safinamide, which is similar to rasagiline, an MAOB inhibitor. It has slightly more widespread effects on brain systems, not just on the dopaminergic system, but also on glutamate release, which may be an issue for excitato neurotoxicity. It can improve on time if you add it to levodopa, and there's emerging reports that it can improve some non-motor dysfunction, even some cognitive decline. There's some papers coming out now suggesting that. We're starting to use it now. There are some contraindications, and you've got to be careful co-administering it in terms of the exact time with some drugs. But yeah, I must admit, I don't think I've got a big enough experience myself to say clearly that it's been that helpful, but we're starting to use it. That's probably the latest drug that's got PBS support in Parkinson's. So I have the next slide, please. Okay, so when we're starting to reach the stage when the dopa-responsive patient we're talking about is having to take very frequent medication, or if dyskinesia is a major issue and we want more even stimulation, then we have other types of advanced therapies, and we have a number of patients on these, small numbers. Apomorphine, which is nothing to do with morphine, it's a dopamine agonist, similar to Cifrol, pramipexole, but it's much more potent. And it can be given by continuous subcutaneous infusion, or they now have a pen jet, which for people who get sudden off periods, it works really quickly. So they just give themselves an injection by pressing like this little pen, and that can be useful. Duodopa is more invasive because you have to put a PEG jejunal tube in, but it can get away from gastroparesis, and it can be certainly useful. You can reduce the amount of dopamine, and that's basically levodopa gel being pumped straight into the gut. Then we have varying forms of deep brain stimulation. When I was a neurologist at Charing Cross Hospital in London before I came back to Australia, we used to do a lot of lesional surgery on Parkinson's patients, and using probes and freezing, we basically burn a small area. So you would do a burr hole and use stereotactic surgery, neurosurgery, to freeze a part of the brain, the thalamus, subthalamic nucleus. And it was amazing. You'd see people come in on a Friday and up, they'd have their surgery, and see them on the Monday, and really it was quite extraordinary. But then deep brain stimulation came in, and the machines used to stimulate because it's much more controllable. Each electrode has 4 different stimulation points. It's very expensive on the other hand, and there's not that many slots at all funded by Medicare, so it's really not something that's open to everyone. But apomorphine infusion, duodopa, of course, is not so expensive and supported by the PBS. So we've got many more people who have been treated with that. Can I have the next slide, please? Okay, so I think we'll go on to the next slide. I think I've talked briefly about surgery, and that's basically what the people making the devices would like us to do is to get earlier and earlier patients treated with DBS, but I don't consider it unless people are getting down to medication every 2.5 to 3 hours. There are some cognitive contraindications, so you can't really use DBS if they've got significant cognitive impairment or psychiatric conditions. Can I have the next slide, please? Almost there, I think.
We just got a question from Jenny before we move on, Dr. Hawke. She's wanting to know, has there been any advances in deep brain stimulation treatment which avoids the loss of ability to modulate the voice?
I mean, voice and hemiparesis are complications, but I don't think there's been any advance in the technique. It's basically the electrodes are being put in the same place, but most patients don't have severe problems with speech. Some do. So, but yeah, they haven't changed their. I'll come on to the next slide. These are the various sites where the DBS is aimed at, and then the next slide, they have done. This just shows an STN site, subthalamic nucleus, which is the commonest site, and then there have been studies. Go to the next slide, of comparing different sites, and there's some factors that favour one site over another, but there's no site, to my knowledge, that can avoid all potential risks. So it's not something that is going to be completely risk-free. I agree, Jenny. But I would think most of the patients that I've had that have had DBS have not had huge complications, and often they're much better controlled on the motor side. So it sounds like you've come across a patient who had a bad outcome. Go the next slide, please. It's also quite useful for severe dyskinesia in some patients. Okay, so this is a new treatment. This focused ultrasound. I guess you've seen this in the press. We've got a machine in Australia at St Vincent's Hospital, and Steve Tish is a neurologist colleague of mine, and Ben Yonker, who comes up to Orange. He does the neurosurgery, and it's sort of like a non-invasive, in the sense you don't have to crack the skull, but it's invasive because you're causing a brain lesion. But it's akin to what we used to do by putting a probe into the same site and burning a part of the brain. You can now do it without cracking the skull. And at the moment, it's not something that they can do that quickly, so they might be able to do 2 cases a day. And it's being predominantly used for treating essential tremor rather than Parkinson's, but there's no reason why it couldn't be used for Parkinson's, as we used lesional stereotactic surgery in the past. So that might be something that, when the backlog of people with essential tremor have been treated, unfortunately, of course, it's not funded by Medicare, so that's a big impediment to its use. Could I have the next slide, please? So basically, you have these multiple beams of high-frequency ultrasound. The patient wears this, I think it's on the next slide, and where these beams intersect, you get heat. And it's greatest where each of these beams, 1,000 different beams, are going through the brain. It's a bit like a stereotactically focused radiotherapy. And at the intersection, you can make a very small hole in exactly the right site. And it's related to temperature. So you can start off by working out if you've got the right site by not heating the area to a degree that you're going to cause the neurons to die off. You can just stun the neurons and see whether the patient is, you've hit the right spot, their tremor is gone, and then you can crank up the energy and cause the lesion. And you're left basically with a hole in the brain on MRI. It's quite neat. So the next slide. Okay, so if we can just see, okay, so this is a patient before and after. So it's a bit slow, but what we're seeing is that this guy had a terrible tremor. He spilled his cup all over the place, and then after he had his surgery, he had virtually no tremor. Of course, they're showing you, this is from Ben Yonker, and this is, obviously a very good patient. They've now analyzed, I think, about 20 patients. It seems to have a long-term durable effect, and probably about 70 to 80% of patients can have a substantial improvement in their tremor. So you usually treat one side only, the dominant side. And I'm sure we all know that we all have patients who have disabling essential tremor. I'm sure you know that the patients are sometimes thought to have Parkinson's, and as I said earlier, that's often because the essential tremor becomes much slower as they get older. It comes down more into the 5 hertz range. But the pharmacological therapy for essential tremor is really a big problem. I only have a few drugs that work. Okay, could I have the next slide? Okay, so basically, I hope that I've just run you through Parkinson's. What you can see is that we're continuing to fail to produce therapies which target the neurodegeneration. And I'm always been particularly interested in antibodies targeting the misfolded proteins in these various diseases. Well, I can tell you with CJD, and I was involved in some of the early work with that antibodies don't seem to do anything. With targeting the misfolded protein in Alzheimer's disease, there's been one controversial study, and the FDA knocked it back, where a drug from Biogen called aducanumab targeted the aggregated A-beta specifically, and there were subclasses of the trials. The overall primary endpoints weren't met. They tried to get it through the FDA and failed, so they're going to have to go away and do more trials. And there were 2 very large multi-center international trials. Some centers were in Australia. And the same for Parkinson's. There's currently several trials of antibodies aiming to target the misfolded fibrillar alpha-synuclein, and we just don't know the results, but I think it's very unlikely that it's going to work in Parkinson's if it hasn't clearly worked in Alzheimer's. So gloom and doom, I'm afraid, for neurodegenerative disease, and any advances, I'm afraid, are rather minor jumps. And unfortunately, as you all know, if you've had Parkinson's for many years, most patients are very difficult to treat on the motor side, and particularly in the non-motor side. Can't really do anything much for dementia. And dementia for Parkinson's, talking about sleep-wake cycle inversion, is pretty similar to Alzheimer's. Hallucinations are often difficult to treat. They're in part driven by the therapy, but they're not, because they seem to correlate with the presence of Lewy bodies. And there are many areas in Parkinson's: postural hypotension, impotence, incontinence. There are many areas where there are tremendous problems. So much so that amongst neurologists, there's a general saying that it's very important to leave the area you work every 7 years. And so you get a new cohort of Parkinson's, because the first 7 years is easy, and then it becomes very difficult. And I've been here since 2004, I'd have to say, so I haven't moved. But those of you who are working in nursing homes, GPs are the ones that are really dealing with the difficult patients, and they can be extremely difficult. Having good psychogeriatricians is extremely helpful, and I refer people on and get advice from them quite frequently. But at the end of the day, we're really not making a huge inroad into improving the life of people with advanced Parkinson's. It ends up being a really bad disease, unfortunately, in most patients. So if anyone has, I'm sorry I've gone over. I've taken a few questions on the way through, but if anyone's still here, I can certainly take some more questions.
We've got a question from Claire. Do you have any recommendations on non-medical therapy, such as physio?
Yes, I haven't mentioned that. Physio is really important. And there's a whole type of physio, based on a combination of motor exercises with cognitive exercises and that is really helpful. So much so that some patients, really want to try and come off their treatment sometimes. I certainly get the impression that those that are actively involved in vigorous physiotherapy and things like PD Warrior program, that has been validated as being effective as an adjunct to improving motor and cognitive skills. So yeah, I didn't mention that. I should have done. That's really important.
Another question from Nirashini. Can you please explain the difference between Matapar, Sinomet and Stalevo and the indication and their indication, or can they be interchangeable?
Okay, so whether you start, so levodopa is in all of them. That's the substance that's turned into dopamine, the chemical that's deficient. So each of them have levodopa. Each of them have slightly different combinations of the other drug to stop the breakdown by dopa decarboxylase in the periphery with Sinomet and Matapar. My general experience is that I tend to start with Matapar rather than Sinomet, and the other drug name is Kinson, which is exactly the same as Sinomet, 100/25, because it seems to have it seems to cause less nausea, but effectively they should be equipotent in terms of reversing the motoric symptoms. Stalevo is basically Sinomet plus entacapone, so it's 3 drugs, and the COMT inhibitors is basically another system which breaks down dopamine. There was the first COMT inhibitor that came out, which we used in the UK, had a pretty marked activity on central COMT, topicapone, but unfortunately that caused severe liver failure in patients and was taken off the market. What we don't have, and which will be really good, and this is available in the UK, is apicapone. That is a COMT inhibitor, similar to entacapone, which is the 3rd drug in Stalevo. And that can be given once a day. So if we just had apicapone, we could just add that to Matapar or Sinomet. But if we want to use the next line of drugs, which is like Stalevo, and we're using that really to iron out motor fluctuations, to get a longer period of control before the next dose kicks in with either Matapar or Sinomet, we have to use Stalevo. But apicapone, I'm not really sure quite why it's not out here. It's been in the UK for quite a long time, but that would be really because we could add it to each. So they're the differences between the two. We're not allowed to prescribe Stalevo initially. You have to show motor fluctuations on either Matapar or Sinomet. Now, of course, Matapar is complex, and it's often very confusing because there's loads of different forms of it. There's a rapid form which comes and goes within half an hour. You dissolve that in water. Matapar rapid, that's called. That's no good if you want people to have a 3 times a day dosage, because it's not going to cover most of the treatment period. Then there's another drug called Matapar HBS, which is a capsule, which is supposed to leach out of the capsule more slowly. That drug isn't, unfortunately, that effective, and it's not as effective as Stalevo, and at prolonging the effect of a given dose of levodopa. There is Sinomet CR, but it's not been able to be synthesized or hasn't been available for a long time. So there have been problems with the supply of these drugs. I'm not quite sure why, whether it's got anything to do with the virus. I don't think so, because we've had problems with Sinomet even last year, Sinomet CR. But there are lots of different forms, and they are confusing. There are other confusing factors too, that with Cifrol, for instance, you start with 0.375 of a milligram, and then several times, in fact, one this week, but this has happened a number of times before, the patient gets 3.75 from the pharmacist, and then they have terrible side effects. You know, they almost become comatose. They get that. So just be careful that we're on the right page with the actual doses. And then there are different, with Matapar, there's 200/50 as well, the higher strength one, and there are lots of different forms of Stalevo. And then if you find that the patient needs more, and sometimes patients need a lot of levodopa to reverse the motoric symptoms, and they might even need, 400 milligrams of levodopa at each dose. So if you're going to use Stalevo, you have to add in a Sinemet or a Kinson to make up the shortfall, because you're not allowed to take 2 Stalevos, because that's the maximum permitted safe dose of entacapone, 200 milligrams with each dose of Stalevo. So don't give the patient 2 tablets of Stalevo at once, because that'll cause toxicity. Any other questions?
Got a question from Yen. Would the chances of developing dementia from Parkinson's reduce when treated early with pharmacotherapy such as dopamine agonists?
Unfortunately, no. The dementia is a factor of the progression of the underlying neurodegeneration. We didn't talk about the stages of Parkinson's, but I mean, there's a lot of debate about whether this is correct, but there's this BRAC stages of Parkinson's. So stage 1 and 2, you just get anosmia, and you can get REM sleep behavior disorder, because that's the where the Lewy bodies are. They're in the olfactory neurons and in the basal and in the brainstem. Then it progresses. It sort of spreads up the brainstem and then into the deep nuclei and then out into the cortex. And the pathology in the cortex and the spread of the alpha-synuclein, these protofibrils, we have no way of influencing. So unfortunately, there's no way of stopping someone having dementia. About 40% of people will have dementia now at 10 years and 80+% at 20 years. However, usually people with dementia and Parkinson's get it later. The traps are in people who don't have much tremor, so the non-tremulous forms, which are symmetrical. Those patients then have early dementia, and whether that's a different disease or not, I'm not sure, or whether they have more rapidly infiltrating alpha-synuclein protofibrils and neurodegeneration. That seems quite likely. But there's no drug that we have that will influence the rate at which the neurons die off. And that occurs, that's the same for any neurodegenerative disease. Now, maybe I should just say that sometimes you see the patients and they come in, and after you've seen them for 3 or 4 years, you start to think, this goes back to something what I said before, hey, you don't seem to be getting any worse. Always think, have I got the right diagnosis? Don't be afraid to think that you've got the wrong diagnosis. I then would start weaning the patients off the treatment, and then sometimes it's clear that they didn't have Parkinson's. Well, unfortunately, sometimes, they're not going to be very happy because you've got the wrong diagnosis. But there's nothing we can do about that. There's no laboratory test that's definitely diagnoses Parkinson's. We don't have fluorodopa PET scanning. There are some features in standard FDG oxygen PET that might differentiate Parkinson's from Lewy body dementia or Alzheimer's. So if you've got cognitive impairment, that can be sometimes useful. Sometimes we do SPECT-CT or SPECT blood flow studies that we can do in the country in Bathurst Orange and Dubbo. But PET is more is more sensitive and more anatomically correct. But if you go into the PET literature and dementia and Parkinson'S and Lewy body dementia, just Parkinson's disease, it's not at all completely clear cut, but that can sometimes be useful. Sorry. Any other questions?
Look, a couple relating to mood disorders. The first one's from Nermit. Are SSRIs okay to treat depression in Parkinson's?
Yes. There's some Parkinson's experts say if you don't get control with an SSRI, try a tricyclic, because some Parkinson experts think that tricyclics work a bit better, say Allegron or amitriptyline. Problem is cognitive side effects. If sleep is a problem, maybe you'd use something like mirtazapine. Anxiety is terribly common. 40% of people with Parkinson's have terrible anxiety. Psychological input from psychologists is very important, just as more important probably than drugs. But standard SSRIs are not an issue. And if patients are on Azilect, I wouldn't be fussed if you're just using SSRIs. Depression, that's the other thing I was going to say. There are some patients who, for instance, may not be on a dopamine agonist, that you might consider putting them on a dopamine agonist, because dopamine agonists like pramipexole sometimes work in severe depression. And, you might even think of increasing the dose. I tend not to use huge doses of pramipexole. So that can certainly elevate mood. So that's another thing to consider. If cognitive decline is an issue, ribostigmine patch. We have to say that the patient has Alzheimer's disease, but I don't think that's a problem, because there can be mixed pathology in elderly people, of course. And the patients have got cognitive decline, and patients with Parkinson's get mild cognitive impairment, just like patients with who are heading towards Alzheimer type dementia. So I think we just prescribe them, but again, they're not unfortunately affecting the underlying progression of the disease.
Got another question from Tracy. She's heard of a Nupro patch. Is it a good option?
Yeah, look, I like the Nupro patch because it sort of gives even stimulation. And maybe that's a bit old type thinking, that it's the swings of stimulation of the downstream receptors that predisposes you to dyskinesia. It's very convenient. For a long time, they couldn't get the stability of the patch right in our hot weather. And if you're sweating a lot, it can be a problem. And if you're a few people who get sensitivity to the patch, it's pretty obvious. You get a bright red square or oblong reaction. You can't continue with it. One problem with it is it's 4 times less potent milligram per milligram compared to pramipexole. And I mentioned earlier that switching people from pramipexole to the patch, you can end up precipitating dopamine withdrawal syndrome unless you use a lot more of it. So if you think about the standard dose of pramipexole, the full dose being, say, 4 milligrams, 4.5 milligrams, then you'd have to use 16 milligrams of the Nupro patch. And the PBS, the maximum amount is 8, I think. So you have to use more than one patch, and that's 2 scripts. So I simply don't understand why the drug company hasn't put, a stronger patch into the market, but it's not available. So that's the downside of the Nupro patch. And just be aware that the patient shouldn't be worried if, for instance, they forget to change it and they wake up the next morning and say, hey, I forgot to change it overnight, because it lasts 30 odd hours, or the half-life's over 30 hours. So there'll still be plenty of patch there the next morning. So yeah, look, I certainly prescribe Nupro patch.
Another question from Babatunde. I hope I've pronounced that correctly. How effective is the infrared light therapy for Parkinson's, and can apomorphine cause postural hypotension?
Light therapy, yeah, that's a difficult one. One of the main reasons why the MR-focused ultrasound treatment that I touched on in the end to burn a hole in the brain, the reason that it doesn't work is that your skull is too thick. So if you've got a thick skull, the high-frequency ultrasound doesn't get through. There have definitely been experiments in mice showing that it can have some sort of neuroprotective effect. But if you know how thick a skull of a mouse is, and look at, again, going back to the thickness of a human skull, I can't think that it could possibly work. So I personally think it's placebo. But a lot of people are using light therapy. It's never been subjected to a proper clinical trial, of course. You could say cannabinoids as well. A lot of people are taking cannabinoids, but again, it hasn't been shown to be effective in a clinical trial in terms of neurodegeneration anyway. Maybe cannabinoids might have some effect on tremor. There have been some studies showing that. As far as pramipexole causing postural hypotension, it tends not to cause as much postural hypotension as levodopa. It can cause labile hypertension, on the other hand, so just watch that. I think if the patient have got postural hypotension just on pramipexole, you could certainly stop it, but I would be thinking either another drug, and here diuretics are a really bad combination for Parkinson's patients, reducing intravascular volume, or the patient has already got autonomic dysfunction, with central autonomic dysfunction causing failure repressor reflexes, could be the underlying issue.
That seems to be it for the questions. Thanks so much, Dr. Hawke, for answering those.
Okay,
There is a
thank you
slide
so much
here about.
for coming along.
Thank you for
Hello?
speaking for us. Hopefully you've had a chance to complete an evaluation there with the QR code. And if you have any queries about the movement disorder nurse specialist pilot, which should be up on your screen now, you can contact Alison Stoker at the PHN. Thanks everyone for coming tonight. Thanks, Dr. Hawke. Have a good evening.
Thank you. Thank you.
Good night.
Thanks so much, Dr. Hawke.
Sorry I went on so long.